Hello, everyone. Thank you for joining us today. My name is Luke. I'm one of the education directors for SUPTA. And this week we are focusing on flank pain under the subtopic urology. We're excited to have you all with us today. So I'm joined by Shoma and Fadi, who will guide you through today's topic of flank pain. Shoma and Fadi are third and first year medical students from Plymouth Medical School. To make these sessions as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form. If you complete this, you will receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and pass the MRCS. Additionally, this session is being recorded and the recording and slides will be shared on our medal page a couple of hours after the session, so be sure to keep an eye out for that. We're also excited to share that an exclusive question bank and other resources will be available on our learning portal, so be sure to check out our website to access them. If you create a free membership account with us, you'll automatically receive a discount code for 10% off the Geeky Medics anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code that we'll provide. The more sessions you attend, the higher your chances of winning, so be sure to stay until the end of today's session and attend as many of our other sessions as well. And just finally, before we begin, we'd like to thank our partners, who are the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I will hand over to Shoma and Fadi.
Hi, everyone. So I'm Fadi. I'm going to start the session off. So today, the things that we're going to discuss are the gross anatomy of the kidney and the neurovascular supply of the kidney itself. Then we're going to look at clinical features of pyelonephritis, one of the pathologies that happens in the kidney, and the difference between the pyelonephritis and lower UTI, so lower urinary tract infections, as well as the investigation and the basic medical management in tackling these 2 things. Then we're going to look at the anatomy and the neurovascular supply of the ureters. And then we're going to discuss an etiology that is involved with, we're going to discuss a pathology that's involved with the ureter, which is renal stones, so renal calculi, and medical management for that as well. Then I'm going to pass on to my colleague, and he's going to discuss the congenital abnormalities of the kidney and the surgical significance, and then also renal cell carcinoma, so malignancy in the kidney, and the clinical signs of that. So we'll start with the gross anatomy. So the kidney itself is retroperitoneal, so it's on the posterior aspects of the abdominal cavity. It is at the level of T12 and L3, so between T12 vertebrae and L3 vertebrae. So that's the entire kidney itself. Now, as you can see in the image on the right-hand side, the right kidney is a bit lower than the left kidney, and that is due to the liver being just superior to it, so it pushes it a bit lower. The left kidney will be protected by the rib 11 and rib 12, whereas the right kidney will be mainly protected by the rib 12. That is mainly due to the liver pushing it further down. The hilum of the kidney, so the opening of the kidney where all the neurovascular supply goes in and out of the kidney, is at the level of L1 for the left kidney and is at the level of L1 and L2 for the right kidney. So that's also due to the liver being on the right side, pushing the right kidney down. Okay, so the hilum of the kidney. So we just said that for each kidney is a bit different. So the right kidney is a bit lower, and in the hilum of the kidney, few things come out. And I've used this mnemonic here called VAP. So this is from anterior to posterior. So it's as if you're looking at the kidney from the anterior aspect. So V stands for vein. So first you have the renal vein, then you have the artery more posterior to it, so the renal artery. And on most posteriorly, you have the renal pelvis or the ureter, so where the pelvis stems out, where the pelvis is, that's where the ureter stems out from. So on the most posterior aspect, you've got the ureter, and that's key to know, especially in surgical practice. Now, here we have the superior mesenteric artery, which is at the level of L1. Then we have the celiac trunk at the level of T12. So we can see that in the image here on the right-hand side. So we can see the celiac trunk, the most superior structure here. And then we have the superior mesenteric. And as you guys can see in the image, the superior mesenteric actually descends down and it goes right over that vein, the renal vein, especially here. And this is going to be where this is going to be the left side, right? Because we can see the vena cava is on the right hand side. So that is quite important, and we'll discuss that a little bit more in a second, because there's a pathology that happens there due to the superior mesenteric artery crossing the renal vein. And then finally, we have the superior suprarenal artery. Now, this is more superior to the celiac trunk, so we can't really see it on this image. But that artery supplies the suprarenal gland, as the name suggests. So that's the adrenal gland. And also we have an inferior suprarenal artery, and that actually comes from the renal artery itself, so not from the aorta. And both those arteries will supply the adrenal gland. Okay, here on the image, we can see something, and we can this vein here, and this vein is called the gonadal vein. And the gonadal vein is quite important, and there's a specific slide for that in a minute, and we'll discuss it. So the vascular supply of the kidney itself, so after the renal artery exits the aorta, it will go into the hilum, and it will supply the kidney in segments. So we've got the anterior aspect and a posterior aspect, and it sort of branches off and makes a posterior branch and an anterior branch. So the posterior will supply the posterior aspect, the anterior will supply the anterior aspect. And once it enters into the kidney, it will split into different segments. And these are called segmental arteries. And we have 5 segmental arteries, as the bullet point suggests. And on the image, you can see them here. So they're all branching off into each segment of the kidney. And if we follow the segmental arteries, they will make these, arched arteries. And because they're arched like a bow, they're called arcuate. So arcuate arteries. And anything that's a bow-like, like a bow arrow, or an arch is called an arcuate in the body. So we have an arcuate ligament. Anything like that in the body is called an arcuate. So here we have the arcuate arteries, and from the arcuate arteries, we have small little branches that come out from it. And these are the intralobular arteries. And the intralobular arteries will make different little branches, and these will be your afferent arterioles, so the ones that actually go into the nephron itself and supply the blood supply there in order for filtration to happen. So the gonadal veins, and just shown it in the image previously. So these are quite important because there's a variation in this. So we have a right and a left gonadal vein. And we can see here, this is for males because we've got the testes, and here for the females. Now the right gonadal vein will go into the actual the IVC, the inferior vena cava, whereas the left gonadal vein will actually go all the way up. So it goes further up into the renal vein. So into the renal vein, and it puts the blood into the renal vein. So there's a variation there, and that's quite important. Now, if we have a renal cancer that presents in the left side of the left kidney, that can travel down the left gonadal vein. And when it travels down the left gonadal vein, it can present into the scrotum. So it can present with something called left-sided varicella, which is an enlarged vein in the scrotum, right? Because of the anatomical location and connection between the two. Okay. Now, the nutcracker phenomenon is what we talked about a minute ago with the superior mesenteric artery. So we can see in the image on the right-hand side, the superior mesenteric will go over the left renal vein. And when it goes over the left renal vein, it can actually compress it down. And when it does that, a lot of issues can happen. So if we compress it, you can just think about it. It will prevent any drainage from the actual kidney itself. So the kidney will become swollen, it will become filled with blood. That can actually impede the whole arterial blood flow because you have less blood flow that's flowing back into the vena cava and less blood going into the heart itself. But also you have less blood going into the kidneys now because of those kidneys being filled with blood and the blood is not leaving them anymore. So that affects the kidney filtration rates as well. Now, if we think about our gonadal vein anatomy, we know the left gonadal vein it does actually go all the way up into the renal vein itself, the left renal vein. And so if we have a blockage there, right, that will affect that left gonadal vein. As a result, you can have testicular infarction, right? Because you have less blood flow going into the testes now and less blood leaving them as a result. Okay, so the innervation of the kidney. So we have sympathetic input, and sympathetic input tends to happen through ganglions. So we have a pre-ganglions and post-ganglions. And in terms of the thoracic duct, so where the actual prevertebral ganglions are. We have a celiac ganglion and we have a superior mesenteric and inferior mesenteric ganglion where all the splenic nerves actually come in. And so the sympathetic input is from the thoraco lumbar splenic nerves, and those synapse at the renal and the celiac ganglia down here, and they provide sympathetic innervation into the kidney. The parasympathetic input is by the vagus nerve. So parasympathetic nervous system tends to be called the craniosacral system because you have cranial nerves that supply the parasympathetic input, and also you have branches from the sacrum itself that supply parasympathetic input. And so here we have the cranial nerve that does it for the kidney, which is the vagus nerve. And it does a whole bunch of things in the abdomen. So the kidney is one of them. We have sensory nerves from spinal cord T10 to T11, and those sensory nerves will actually show the symptom of flank pain as a result. So we have kidney problems, we present with flank pain due to the nerves running into T10 and T11. The renal fascia. Now, the renal fascia, there's different literature that actually separates the fascia into many different categories. But for clinical practice and for most anatomy exams, all you guys need to know is the Grotus fascia. And this fascia sort of encapsulates the kidney from the anterior, posterior, and the lateral aspect. So the kidney is protected from all these sides. And within the fascia, you have something called the perinephric fat. So it's fat around the kidney that keeps it protected. Now, in the inferior aspect of the kidney, there is no fascia, so it's actually completely open on the inferior aspect, and that's quite important. So, the importance of the fascia and the clinical significance. So, the fascia acts as a natural barrier, so it prevents further spread of infection because of that encapsulation. It also allows for self-contaminated hematomas, because there is no actual opening. So therefore, if you have a hematoma in there, it will be self-contained and it will create a tamponade. And tamponade is anything like a blockage, so it keeps it in there and doesn't let it leak out. Now, if you do have a fluid that is leaking, it tends to go all the way down into the abdomen. Why? Because the inferior aspect of the kidney is not covered with fascia, right? So anything can flow all the way down into the pelvis, sorry, not abdomen, into the pelvis, and that can cause pelvic pain. Also, because we have fascia on all aspects of the kidney, except the inferior aspect, that can lead to kidney dropping. So a kidney ectopy, so a kidney out of place or anything like that, can be due to kidney already ascending, but it drops further inferiorly because it's not protected inferiorly by a fascia. Okay, so the kidney relations, so where everything else sits in relation to the kidney, and that's quite important. So on the left kidney, we're going to have Um, a way to remember it is pancreas tackles spleen. Um, so the pancreas will go over the left kidney and it will tackle the spleen, and the spleen sits there on the lateral aspect of the left kidney up here. Um, and the pancreas will touch the spleen. Therefore, you can always keep them together. That's a good way to remember that relation. Also, we have the suprarenal gland, of course. So suprarenal area up here, the gastric area. So the stomach will be up there. Also, on the inferior aspect, we have the colic area and the duodenal area, so it's the intestines. And the right kidney, a massive part of the right kidney will be covered by the liver. And between the liver and the kidney, we have a space, and that space is called the pouch of Morrison. So here, the right name is hepatorenal pouch of Morrison. And that pouch between the right kidney and the liver tends to be empty, so it's not filled with any fluid. But however, if you have a bleeding in the abdomen, in the peritoneal, that can get into that pouch. And that can be spotted on an ultrasound and it can be spotted on a CT. So you know there's a problem there if there's fluid within that pouch. Now, of course, here on the right kidney, we also have the suprarenal area because of the suprarenal gland. And also on the inferior aspect, we're going to have the intestines as well, just like on the left kidney. So it's pretty much similar otherwise, except that the liver sits on the right side. So the posterior aspect of the kidney, and this is quite important, especially if you're doing a posterior approach into the kidney. So if you are doing a surgical procedure and you're going from the posterior aspect into the kidney, this is quite important to be aware of. So we have one artery, three nerves, and four muscles. Now, there's also bones, right? Because we said that the kidney is protected by the ribs, rib 11 and rib 12 protects the kidneys. So a mnemonic here that could be useful is 1, 2, 3, 4. All boys need muscle. And 1 is for A, so all. So 1 is one artery. 2, uh, so group 2 with boys. So 2 will be 2 bones. So we know that those are the 2 ribs that protect the kidney. 3, we can group that with need. So 3 nerves, and those are the nerves up here. So we have the subcostal, the iliohypogastric, and the ilioinguinal nerves, and those are on the posterior aspect. Now we have 4 muscles that are posterior to the kidney. So we have the diaphragm, right? Because the diaphragm will dome and it will attach to the L1 vertebrae. So we've got the diaphragm on the posterior aspect. We also have psoas major, and psoas major is really important because if we have an infection in the kidney, that can travel down psoas major muscle. And psoas major is a major flexor of the hip, so it joins with iliacus later on, and it makes the iliopsoas muscle. So it flows all the way down to the pelvis. So that could be a route for the infection to flow down. Then we have quadratus lumborum, and you can see that as a muscle that's adjacent to psoas major, and it has similar shape. And then we have transversus abdominis, and transversus abdominis goes um, around the abdomen area. It goes into the posterior sort of fascia, and therefore it kind of covers the kidney from the posterior aspect as well. So the mnemonic is 1, 2, 3, 4. All boys need muscle. That's a good way of remembering all the posterior structures of the kidney. So the internal anatomy of the kidney, and I'm sure many people are aware of this, especially as medical students, um, we will have a capsule on the outside of the kidney. And further inwards, we're going to have the renal cortex, so the outside of the kidney, the cortex of the kidney. And from the renal cortex, we're going to have renal columns. And these sit between these structures here. And these structures are the renal pyramids, right? Because they look like a pyramid. From the renal pyramid, you're going to have a renal papillae, and these are the ends of the pyramids. And from the renal papillae, you're going to have the minor renal calyx or calyx. So you have 2 calyces. You have a minor calyx and a major one. So the minor is just at the opening of the pyramid where the renal papillae is, and then that drains into the major calyx of the kidney. And from the major calyx, you're going to go, and then everything is going to join together into this structure here, which is the renal pelvis. And if you remember from the beginning of the presentation, I said the ureter itself that flows all the way down to the bladder is draining from the renal pelvis of the kidney. So the nephron itself, the nephron will receive blood flow that's going into the kidney, and it will filter that blood flow, and it will drain many toxins and reabsorb many nutrients. So it's really important. So what we're gonna have an afferent arteriole. An afferent, I always think A because for arrival, because it's arriving into the kidney. So an afferent arteriole is going to go and it's going to make the glomerulus, right? And the glomerulus is the kidney is this, and this is convoluted structure of arterioles, right? And they're going to sit into something called the capsule, the Bowman's capsule, and that's where all the blood is going to flow uh, um, into the kidney to be drained into the nephron. So within the Bowman's capsule, everything from the blood is going to be filtered, and that flows into the proximal convoluted tubuli up here. So the proximal convoluted tubuli, because it's convoluted and it's proximal, hence the name, is going to flow into the descending limb, right, of the loop of Henle. And then from the descending is going to flow into the ascending limb. And the ascending limb has a thin and a thick area up here. And if we look at this image, if we look at this image below here, we can see that it's flowing from the cortex into the medulla. So it's going to go, the nephrons, the proximal aspect of the nephrons can be in the cortex, and the loop of Henle is going to flow into the medulla. And the medulla is very salty, so it helps with the reabsorption of water. And as if when we ascend back up, we're going to have the distal convoluted tubuli. So we had the proximal, now we're going to have the distal convoluted tubuli, and that's going to drain into the collecting duct up here. And the collecting duct flows all the way down, and many nephrons, so you can have multiple nephrons that all drain into the same collecting duct that collects that urine to be drained back, out into the ureters. And that's how the filtration process happens. So the anatomy of the ureters, and I'm going to talk about the anatomy of the ureters before the pathologies because it makes sense to put the anatomy together and then discuss the pathology. So the anatomy of the ureter, so this begins in the kidney from the pelvis, right? And that junction between the pelvis into the ureter is going to be called the ureter-pelvic junction, right? So just put the two names together and that will make sense. Then it's going to pass anterior to psoas muscle. So if you remember, we discussed that there's this psoas muscle that flows down, and there it is here. So we have psoas major right here. We also have a psoas minor, but not in all people. But psoas major is the main muscle that is important. So it's going to pass anterior to psoas major muscle, and then it's going to enter the pelvis. Now it's going to enter the pelvis at the iliac bifurcation. So here, there's the common iliac artery, and the common iliac artery was split into two. It's going to split into the external and the internal iliac artery. So the ureter is going to cross right over that bifurcation, and it's going to flow down into the pelvis. And then when it flows down into the pelvis, it's going to reach it's going to flow on the posterior lateral aspect of the pelvic wall before it reaches the actual bladder. And at the bladder, it's going to make another junction. And that junction and the bladder is called the ureter vesical junction. And, it just means that it's from the ureter into the sac, which is the bladder. So there's that junction there. And these junctions are important. So there's three important bits here, actually. The first junction, the bit where it crosses the iliac bifurcation, and the bit where it joins the bladder. And all of these are important for kidney stones. And this is just a quick slide on kidney stones. We'll discuss it in a bit more depth later on. But these are the common sites where kidney stones get stuck. So we have the pelvo-ureteric junction at the start here. So that's a common site where the renal stone will get stuck. Also, when it crosses the iliac bifurcation, so here it makes a little angle uh, that is quite sharp, and because of that angle, if the kidney stone is flowing down the ureter, as you can imagine, it can get stuck within the angle when it's going over the artery. Also, when it joins the actual bladder at the ureter vesicle junction, here also when it joins the bladder, it creates an angle, and there in that area, a renal stone can actually get stuck as well. So three places that are important. And this is key when you're looking at an ultrasound or CT, you can predict where the renal stone would be. Sometimes the renal stone doesn't actually flow down, but is an important consideration to think about the junctions. So here we have the vesico urethral reflux, and this is a congenital abnormality that happens at the vesico-urethral junction. So the junction, if we go back to the previous image, is the junction here. So it's where the ureter enters the bladder. So it's a congenital abnormality that happens in children, and that is primary vesico-urethral reflux, is when a child is born with defective vesico-urethral junction, so the junction itself is defective. Normally, the ureter will actually go through the bladder for 2 centimeters inwards. And when it goes into the bladder, when that bladder fills, it basically blocks that opening because of the ureter flowing into the bladder. When it expands, it blocks that opening, and therefore you can't have a urine flowing backwards into the ureter and back up into the kidney. Now, if we have a defective junction here, this process is inhibited, so you don't have a normal functioning process here. So when you have a bladder that's filling up, the urine actually flows back up into the ureters in this case, and can flow back up into the kidney. So the whole mechanism basically fails. Now, the secondary vesico-urethral reflux is basically an obstruction in the tract itself, and that causes backflow into the ureters and into the kidney. Okay, so the wall of the ureter itself, you have a mucosa, and this is the innermost layer, and this is transitional epithelium. An important thing about transitional epithelium is that you can compress it, so this is good for compression. So if you have a lot of urine flowing through, it can compress, and also is non-permeable. So there's no permeability through that transitional epithelium, and therefore you can't have urine flowing out of the ureters, right? And that's really important, especially there's a lot of toxins in the urine. Then you have a muscularis layer, and this is a layer of different muscles. So you have two longitudinal muscles, and then you have a circular muscle layer. And the circular muscle layer is important for the peristaltic movement. So you know the flow of the ureter is in a wave-like motion, and that's the peristaltic movement of the ureters, and that's due to the muscularis layer. This is important in kidney stones, and we'll discuss that in a minute. And then we have the outer layer, and that's the adventitia, and that's the outer layer of the ureter itself. So the blood supply to the ureter, it comes from different places. So the superior aspect of the ureter can be supplied by branches from the renal artery itself. Then the middle aspect can be supplied by by a branch from the gonadal artery. So just like we had a gonadal vein, there's a gonadal artery as well. So that can supply the ureter on the middle aspect of it. Then we can have a branch from the abdominal aorta, supplying the middle aspect of the ureter, and also a branch from the common iliac artery. And all of these can supply the middle aspect of the ureter. Now, on the inferior aspect of the ureter, you have branches coming from the common iliac artery. And I'll put them here. Um, and these supply the inferior aspect. From the common iliac artery, you have something called the vesical arteries, and those make the uterine arteries, and those supply the inferior aspect of the ureter, and sort of anastomose together and create a plexus of vascularity. And so you can actually resect and remove the ureter in segments due to this plexus, because you have alternative blood supply, but you can't actually remove the ureter from the proximal aspect and from the distal aspect at the same time, because then you'll cut the whole blood supply of it. So the innervation of the ureter, so it's quite interesting because it has its own impulses, just like the heart. So there's intrinsic smooth muscles in the calyx of the kidney, so the minor renal calyces up there in the kidney, and those have pacemaker sites, and that can create intrinsic actual innervation to stimulate those smooth muscles. Also, we have sympathetic stimulation, and that comes from T12 to L2, and that creates a ureteric plexus that innervates the ureters. So that's for the sympathetic stimulation. And for the parasympathetic stimulation, we're going to have branches from S2 to S4. So just like we said before, the parasympathetic can be it's called the craniosacral system. So in this case, we're going to have branches from the sacrum, whereas the kidney has a branch from the cranial nerves, which is the vagus nerve, for parasympathetic innervation. So for one of the pathologies, we have pyelonephritis. And pyelonephritis is basically a complication of lower urinary tract infection. So it's a bacterial infection causing inflammation of the kidney. And it's basically when the infection spreads from the bladder all the way up to the kidney. And then you can develop chronic pyelonephritis. And that's when you have recurrent renal infections inducing inflammation and scarring within the kidney. And I put here in brackets associated with vesical urethral reflux and renal calculi. And that's because those two things that we've already kind of discussed uh, cause something called urinary stasis, where the urine is not flowing anymore but sits in its place. And that can favor bacterial growth and favor infections of the kidney. So pyelonephritis is associated with those pathologies. So the etiology of pyelonephritis, well, it can be spread by two ways. It can be through hematogenous spread, so through the blood itself. So if you have bacteria within the blood, and that flows into the kidney, it can cause an infection that way, and that's less common. But the more common way is through an ascending infection. So this is when you have a UTI, so you have a contamination of the urethra from the rectum, and as a result, the bacteria travels up into the bladder and into the ureters, and that results in kidney infection. So the microbiology of pyelonephritis. So E. coli is the bacteria that's most common, and E. coli is part of our normal microbiome. So it tends to infect our gut, um, and as a result is a opportunistic pathogen. So if we introduce that bacteria from the rectum into the urethra, it can travel up there. And when it travels up there, it has these mechanisms where it can resist urine flow. So if you urinate, sometimes it can resist it and stays within the path up into the kidney. So it can cause an inflammatory response, so it can cause scarring of the parenchyma. And as a result, you can have a kidney infection, pyelonephritis, which can result in sepsis and a septic shock eventually. Now, you have other organisms besides E. coli that can cause this. So you have E. coli, which is causing 60 to 80% of uncomplicated infections. Now you have Klebsiella species, which is 10%, and Proteus species, which is 5%. But E. coli is generally the most common for pyelonephritis. Now, the symptoms of pyelonephritis and lower UTI. Lower UTIs tend to be associated with dysuria, so pain, and frequency of urinating and urgency. So that tends to be associated with lower UTIs. Now, for pyelonephritis, it's basically the same symptoms, but a lot more severe. So you have those symptoms, which are more severe, but it's also associated with a few more symptoms. for example, fever, right, as a result of the infection. You also have nausea and vomiting and flank pain as well, typically unilateral. So this is a really key way of differentiating between lower UTI infection and pyelonephritis. If the patient has fever, nausea, vomiting, and flank pain, that would be indicating pyelonephritis. For tests and diagnosis, well, we can have a midstream urine sample, and you want it midstream because you want to have the part where you most likely have the bacteria, which is midstream of the urine. Or you can have a catheter specimen of urine to identify the microorganism. You can also do a dipstick urine test to look for nitrates and leukocytes for infections, indicating infection. So that's a good way, and it's quick. Um, and also for a definitive diagnosis of pyelonephritis, it's the symptoms. So that's what we just discussed a minute ago. If we have those symptoms of fever, nausea, flank pain, those are indicating pyelonephritis. Now, the management of it, antibiotics is your way of treating infection. Analgesia is to treat pain. Non-steroid anti-inflammatory drugs to reduce the fever and the pain. And also starting antibiotic treatment once the sample for culture has been obtained. So if once you get the culture to Center for the Microbiology, you can then start antibiotic treatment, and then you can reconsider the antibiotic treatment after the results have come back. And I put here, and this is from NICE guidelines, if you have bacterial resistance, so if we know the microorganism and it is a resistant strain, and the symptoms are not improving with the previous antibiotic, then you can go for a narrow spectrum antibiotic, right? So that's more specific for that bacteria. The management of lower UTI is pretty much the same. So you have a midstream urine sample, and then you give a antibiotic uh, straight away. Now you consider the local antimicrobial resistant data based on the hospital guidelines, and once you get that culture and you get the results for the bacteria, then you can review the antibiotic and adjust the treatment. And also similar here. So if you have a resistant strain and the symptoms are not improving, you can go for a narrow spectrum antibiotic. But patients with indwelling catheter, now you can arrange for a hospital admission if the patient is very unwell. So if they have tachycardia and hypertension, signs of sepsis and septic shock, then you can administer the patient. Or if that's not needed, then you can actually sort of remove or change the catheter to prevent further infection. But the key bit here is to give antibiotics and then reconsider the culture to give more specific antibiotics that battle the microorganism. The renal calculi, so the renal stones, and renal stones are hard deposits that are made of minerals and salts inside the kidney. And they can stay within the kidney, but also they can travel down. And if you guys remember, from the anatomy, they can get stuck at multiple places. So three junctions that we want to think about when we're considering renal stones. The cause of renal stones can be due to intrinsic factors, so a genetic predisposition. You have ethnicity and gender also play a role. So 3-to-1 ratio of men to women tend to have to experience renal stones in their lifetime. Also, you have extrinsic factors, so water intake, lifestyle, and climate. And I put two studies here that suggest obesity and BMI is strongly linked with kidney stones. So here we have 20% increase of risk of kidney stones when we have a high BMI. Also, there's an increased risk of calcium oxalate and urate levels with people who are obese, and those are key for formation of kidney stones. So pathophysiology. So increased urine supersaturation um, due to an increase in minerals. And we have different types of stones. We have calcium-based stones, so those are 60 to 80%. We have struvite stones, and these are commonly associated with infections like Proteus and Klebsiella, and those are urease uh, producing bacteria, and so they can convert uh, urea into ammonia, and that causes an increase in pH. As a result, you have a formation of these struvite stones that can cause the kidney blockage. And then you have uric acid stones, and those are 10%, so they're not as common. And these are due to protein catabolism and metabolic disorders like gout and type 2 diabetes. But they're not as common. Mainly is calcium-based stones. For the symptoms, you have loin to groin pain, so it's up from the groin up into the loin, or the other way around, because the stone is flowing downwards, of course. Also, you have peristaltic movement of the ureters, right? So you have waves of pain. So it's not a constant pain. You tend to have waves of pain due to the peristaltic contractions. You can have hematuria, so blood in the urine due to those contractions. Also, you have pyuria, which is white blood cells, and that could be due to the irritation caused by the kidney stones, but also due to infection that can be secondary to kidney stones. For investigations, you can use a urine dipstick for hematuria and pyuria. Also, you can use a blood test to check kidney function. But CT and ultrasounds are great for kidney stones because we can see here on the right image from a CT scan, we can see a kidney stone right there. So they're great for definitive uh, diagnosis. For management, non-steroid anti-inflammatory drugs are your first-line treatment. Then you can give intravenous paracetamol for adults and children who need it, and non-steroid anti-inflammatory drugs have not been effective. Also, you can give a combination of those two. And if those are not effective, you can give opioids. And opioids are your drugs to give if none of those things are effective before anything else. You can also give alpha blockers, and those act on androgenic receptors to cause muscle relaxation. So when it causes muscle relaxation, that naturally decreases pain because it decreases that peristaltic compression, but also it allows for the kidney stone to flow much quicker. You can have stenting, and that expands, so it prevents blockage and expands the ureters. So that can be done surgically via the urethra, or it can be done by a radiologist. So it can be gone through the skin through a tube. And also you can have your last result, which is surgical intervention. And there's different types of surgical procedures. So you have shockwave, uh, lithotripsy, and shockwave lithotripsy tends to be for smaller stones, and that is done from external shock waves into the body. So there's no incision, nothing is inserted into the body, but an external shock waves break down those kidney stones and allow them to flow out through the urine. Also, you can have a procedure called ureteroscopy. So you have a scope going through the ureters up into the kidney, and then you can break down the kidney stone with laser fiber or an ultrasound probe, and the fragments are then collected with a basket. So then you hold all the fragments together and pull them all out at once. The most invasive procedure we have, and these are for larger stones, is precutaneous nephrolithotomy, and that is done through an incision through the skin on the posterior aspect. So a keyhole surgery. So it's going through the skin into the kidney, and the stone can then be broken up with beams. So it can be done with laser fibers, so a lithioclast, and or actually you can use a ultrasonic suction probe, and those actually break down the stone, and you can collect the stone and pull it back out of the kidney. But this is mainly for larger stones, and it's the most invasive method. Now, the complications of renal stones, if we don't do those procedures, we can have an infection, right? Because we have renal urine stasis, so there's no blood, urine flow anywhere, so that favors bacterial growth, and we can have an infection, and that can lead to sepsis. Or you can have something called hydronephrosis, so that's swelling of the kidney because of huge amount of fluid not leaving the kidney that can cause swelling of the kidney, and that disturbs kidney function. So it disturbs the glomerular filtration rate. Also, it disturbs. It can cause acute kidney disease. Sorry, which can cause mortality. So it's got a high mortality rate of 20% and over. So overall, that's it for this part of the presentation. We can put the poll questions up, if that's okay. So the first question we have is a knife stabbing from the posterior aspect of the back, just lateral to L1. Which kidney structure is most at risk? And we have different choices. So we have renal vein, renal artery, ureter, and renal nerves. So that's the first question. So what's the structure that's most at risk if we have a stabbing from the posterior aspect? Okay, so I think for that question, I can't see the answers, so I'm not sure if people have answered or not.
So the most common was ureter, 71%.
Yeah, so ureter is right. So if you guys remember that, so VAP, so most anterior will be vein, then you have artery, and then you have the pelvis, which is where the ureter is. So ureter is the most common, will be most likely to be injured as a result of this. So the second question is, what symptoms differentiate pyelonephritis from lower UTI? And you have answers here. So you have dysuria and urgency, frequency urinating and urgency, fever and dysuria, or fever, nausea, vomiting, and flank pain. Which answer do you guys think?
Yeah, 100% going for the bottom one.
Okay, so perfect. That's the right one. So fever, nausea, vomiting, and flank pain. That's indicating pyelonephritis. So the last question is, what is the most common renal stone? And we have options of calcium-based stones, uric acid stones, or struvite stones.
So yeah, 75% going for calcium based.
Perfect. So that's the right answer. So I think calcium based stones are the most common. So they tend to be 80% and over for kidney stones, whereas the rest are less common. So that's the right answers. So now I'm gonna pass on to my colleague, and he's gonna do the next section, which is congenital abnormalities of the kidney.
Hi guys, I'm Shoma. I'm one of the third year. Well, I'm the third year medical student down in Plymouth. So I'm going to be talking about congenital abnormalities of the kidneys, and then I'm going to do a bit on renal cell carcinoma and a little bit about the different types of renal cancers. I've chosen horseshoe kidney and polycystic kidney disease to talk about mainly for two reasons. They're the ones that are likely to come up in exams from the exams that I've done in the past, and also they're the ones that you're more likely to see on the wards, especially polycystic kidney disease. I will say if you want to look at like a resource that's been really good for that's just got all of the kind of congenital abnormalities of the kidneys, I would recommend the osmosis notes page. I found that quite useful. Fadi, could you go to the next slide, please?
Yeah.
So horseshoe kidney is, I mean, as you can see in the picture, it's a fusing of the lower poles of the renal kidneys. Generally speaking, people are asymptomatic. So it starts to fuse around weeks 4 to 6 in the pregnant abdomen, and then gets trapped under the superior mesenteric artery. So it can't go any further up, and it just keeps fusing and fusing. However, due to the abnormal anatomy, you do have blockages in the PUJ. So there's as Fadi kind of talked about earlier on, And thanks to his very extensive anatomy, I don't have to cover too much of it. So with the blockage in the PUJ, you get urinary stasis, which increases your risk of kidney stones, hydronephrosis, infection, and the carcinoid tumors and Wilms tumors. The carcinoid tumors and Wilms tumors, I think, is just based on the fact that it's a congenital abnormality. So you have some genetic predispositions. Can you go to the next slide? So yeah, so polycystic kidney disease. So polycystic kidney disease, you've got two types, as you can see on the slide. You've got autosomal dominant and autosomal recessive. Recessive tends to present in infancy and presents with oligohydramnios, and with renal failure, it's a lot worse. Whereas, I mean, they're both not great, but it's a lot worse than the autosomal dominant variant. It's the most common inherited renal disease, third most common cause of end-stage kidney disease. And as you can see, it's caused by mutation in the polycystin gene, which is necessary for the inhibition of cell proliferation. And then with these cells, the water moves into the cells, causing them to the proliferating cells, which swell up, causing these fairly big cysts. Can you go to the next slide, please? So the presentation for kind of all of the things I'm talking about seems to be fairly similar. You get hematuria, loin pain, hypertension. That's because of the messing with the physiology. So the kidneys are obviously involved in the RAS system. So if you've got some abnormalities within kidney anatomy and within the structural functions of the kidney, you're going to have some abnormalities with the physiology as well. On examination, you'll feel a palpable abdominal mass. They seem to apparently like bringing in people with polycystic kidney disease into your OSCEs and your CPSAs because they can be really massive. And then you can get hepatomegaly as the cysts can travel and proliferate elsewhere in the body as well. I've seen it where it's basically that they've got two kidneys and a liver that's just cystic. So your investigations for it are going to be a renal ultrasound as your first line. It's the most accessible, it's the easiest to use, and it gives you a really good indication as to what might be going on. An MRI is going to be more sensitive for smaller cysts and can be good for seeing cysts kind of generally elsewhere in the body as they can travel, but it's not kind of a first line diagnostic. So management for polycystic kidney disease is symptomatic. Treating the symptoms is going to increase their quality of life quite significantly. But if their EGFR is below 20, you can offer them a renal transplant, and it kind of sits in. So I don't know if you guys have seen I probably should have put a picture up. Sorry about that. But it sits. They don't take the kidneys out. Usually they'll put one and it will just sit in the pelvis. So you'll find on a CT, you'll have these really, really cystic kidneys and then a perfectly healthy looking kidney in sitting in someone's pelvis. And it's really strange, especially if the registrar doesn't warn you about it. And yeah, so with the complications, you can get hepatic cysts, as I talked about. So it tends to kind of move into the liver as well. And you've got an increased risk of cardiovascular disease and intracranial aneurysms. Again, I think this is all, if I remember correctly, it's all to do with the polycystin gene and the kind of genetic predispositions for the intracranial aneurysms, and then an increased incidence of gestational hypertension and preeclampsia. Yeah, thank you. So now I'm going to talk about renal cell carcinoma or renal cancers. I'm going to start with renal cell carcinoma and then talk a little bit about some other types. Renal cell carcinoma is your most common type of kidney cancer, or most common type of renal cancer. It originates from the epithelial tissues in the proximal convoluted tubule. Macroscopically, if you have a look at them, they tend to be quite yellow. And as it says on the slide, microscopically, they appear to be quite clear due to the dissolution of the fat and the glycogen, and they appear yellow because of that high content of fat. So because they're clear, the most common type is called a clear cell carcinoma. Sometimes in exams, if they're being really mean, they might ask what the second most common type is, because clear cell carcinoma is like about 85%. The second most, just for your information, is a papillary cell renal cell carcinoma. But the chance of that coming up is, I feel like, quite slim and would be quite mean. If they're going to ask something, they're going to tell you that it's a renal cell carcinoma and then ask you what the most common type is. So similar to kind of polycystic kidney disease and a lot of like urinary tract cancers, it presents with hematuria, loin pain. You've got flank mass, and then uncommonly, but it can come up. They seem to like it as a question. Is presenting with a left-sided varicocele if the tumor is big enough. So the tumor can then compress the renal vein, and as the testicular artery vein, drains directly at kind of like a right angle, kind of like that, if you can see, into the left renal vein. If the tumor is large enough and compresses that, it can cause a complete blockage and cause obviously a backup of venous blood into the testicles and can cause a varicocele. Can you go to the next? Yeah. So quite a few patients, about 10 to 40% of patients, can also present with some paraneoplastic syndromes. I've just put the most common ones there. So with polycythemia, you get a ruddy complexion due to the increased erythropoietin production. So they come in looking really red. And then with parathyroid hormone parathyroid hormone secretion, you can get hypercalcemia, can lead to fatigue, weakness, constipation, nausea and vomiting, kind of your classic hypercalcemia symptoms. But it's really important to rule out renal involvement with hypercalcemia. So if you do have someone coming in, it doesn't hurt to check their kidney function and maybe do a CT. So your risk factors with renal cancers are your non-modifiable ones are your North American and European heritage. But you do have some modifiable ones such as obesity, smoking, kind of a diet low in vitamins and minerals, and hypertension. I mean, it seems to be kind of your classic modifiable risk factors that you get with everything else, but these are the ones that seem to be specific for renal cancer, renal cell carcinoma. Sorry. So your investigations, you're going to do imaging, you're going to do ultrasound KUB first line, and then a contrast KUB for diagnosis and staging. It's really important that it's a contrast CT, because we want to be able to see the vascular supply. If we don't have a contrast, we can't quite see the extent of the vascular supply of the cancer. And then, so obviously with most cancers, you tend to do a biopsy. Renal cell carcinoma, or at least in this trust, isn't one of those, because the chances of it being a benign renal cell carcinoma are quite low. So still here in the trust that I'm in, they tend to just cut out the whole tumor and just not do a biopsy. But I know that in other trusts, sometimes they're catching them a little bit earlier, and they'll tend to do a biopsy to try and see whether it's necessary to do a radical nephrectomy. So the criteria for the 2-week wait, this is taken directly from the NICE guidelines. So the hematuria without urinary tract infection, or that persists or occurs after a successful treatment of a UTI. Some of the complications that you can get are metastases, IVC invasion, anemia, polycythemia, and a varicocele. Metastases are most commonly lung, off the top of my head, lung, and then obviously because you have that direct link into the IVC, you can get, not very commonly, but I have seen it, that you can get tumor kind of growing into the IVC. And then anemia and polycythemia again happen because of the disruption in the physiological function of the kidneys. Move on, please. So as I kind of hinted to earlier, you've got two main options. You do have the option of a partial nephrectomy. So the partial nephrectomy is offered in if tumors are below T1, or if, for example, a tumor So if it's caught early enough and it's below T1, then fantastic. You know, you can do a partial nephrectomy and save some of that renal function. Or on the other hand, if the other kidney cannot support the body by itself, then, you know, a partial nephrectomy can be done, because at the end of the day, the aim is to make the patient feel better, not worse. And sticking them on dialysis for the rest of their life might not be something that they're really up for. And then the mainstay treatment is a radical nephrectomy. As you can see, the RCCs aren't, so they're quite resistant to chemoradiotherapy. So doing it isn't always the best option. That can be done sometimes to reduce the size of the tumor, but generally they just do a radical nephrectomy. But I know that's changing, and with tumors being caught earlier, we can start doing more and more partial nephrectomies and saving some of that kidney function. But it's not, at the moment, it's not done quite as commonly as maybe they need to be, or we would like them to be. So your second most common type of renal cancer is a transitional cell carcinoma. It is the majority of bladder cancers, but it's only about 5 to 10% of renal cancers. So it stems from the urothelium. So the urothelium is the epithelial layer, endothelial layer that runs throughout the whole of the bladder, but also up the ureters and into the renal pelvis. So you can get tumors all the way up into the renal pelvis, therefore making it a renal cancer. Generally speaking, though, they tend to be bladder cancers, or I've forgotten the word. That's fine. So yeah, so they're the most common form of lower urinary tract cancers. They stem from the urothelium. Again, they kind of present similarly a little bit. You just don't have that flank mass, unless it would be like really big and growing in the renal pelvis. So you can get painless intermittent hematuria, suprapubic pain, especially if there's some local invasion, dysuria, increased frequency, and some nocturia, kind of your classic your lower urinary cancer symptoms. So your risk factors. The risk factors are the ones that they tend to love asking in your exam. PSAC is a great mnemonic, and it's a little bit stupid, which is why it's great, because it will remain with you. So phenacetin, it's a common analgesic back in the day, though it's now banned. So if someone's come in and, you know, they've had a lot of surgery, and now and now they've got these kind of classic transitional cell carcinoma symptoms, then might be worthwhile asking or having a look and see if we can find what medications they were on. Smoking is the biggest risk factor. They love to ask it, and I mean, it came up in my most recent exam. It's a risk factor for all cancers, pretty much, but it is kind of one of the classic ones for a transitional cell carcinoma. Aniline is another one that they like to ask. So the classic question will be: a patient comes in, they've worked in the rubber and dye manufacturing their whole life. They're now complaining of intermittent painless hematuria. What is the most likely diagnosis, or what's the management? And then cyclophosphamide, because it's nephrotoxic. And then there's some other ones. So, you know, being male, HPV, not voiding your bladder for long times, they can all lead to transitional cell carcinoma. But PSAC tends to be the ones that come up in exams and that people ask about, and the ones that are going to be the most clinically relevant. And then your investigations and management is pretty much the same as your renal cell carcinoma. So you're going to be doing a CT-KUB with contrast to find that those tumors. If it is a bladder-based one, they can do endoscopic investigations and go in through the urethra and have a look around, because they're quite distinct in the way that they look. Oh no, sorry, can you go back? So you're more likely to offer kind of a segmental resection of the ureter and the renal pelvis in the smaller tumors, as well as laser treatment, but they can in really large tumors or in extreme cases remove the bladder entirely and make a new bladder from some bowel, or they can just remove the bladder and the person is just bladderless for the rest of their life. Can you go to the next slide, please? And the last thing I'm going to talk about, just because it can come up sometimes, is a Wilms tumor or a nephroblastoma. So they're one of the most common childhood malignancies, typically presenting before the age of 5. They kind of are linked also to retinoblastomas. So if someone's got family history of retinoblastoma, they can present with, they can ask the question, if a person's got a family history of retinoblastoma, they're coming in with an abdominal mass, what is it likely to be? Clinical features, kind of again similar to all of the other ones for renal carcinomas. You've got an abdominal mass that does not cross the midline. That is a really important differentiating factor from, I think, a neuroblastoma. So nephroblastomas do not cross the midline. And then you've got painless hematuria, flank pain, and I've put in the NICE-CKS referral criteria, just because I think that tends to be what our exams are based on anyway. So yeah, that's everything from me. That was a really quick rundown. Sorry about that. But yeah, so I've got some poll questions now. Oh, never mind. So if people are still about, so what type of tumor can present with a left-sided varicocele? Any other responses before we move on? Because I know I don't want to keep you guys too much longer. Cool. So everyone's put renal cell carcinoma. Beautiful. And then we've just got the one last one, and then I'll let you guys go for the evening. What does the C in the PSAC mnemonic stand for? Give you another couple of seconds just to put an answer in. Okay, so 83% have put in cyclophosphamide. So yeah, that's the correct answer. Cyclophosphamide is nephrotoxic and cytotoxic. So it's really important to remember that if someone's on cyclophosphamide, they are, or have been for a longer time, they are at an increased risk of a transitional cell carcinoma. I've put in all the, you can see at the bottom, we've when we send the slides out, we've got all the links and stuff in the references. So yeah, thanks for listening, guys.
Thank you very much, both. That was a very insightful session. I put the feedback form in the chat, guys, for you to fill out. And we also got our Geeky Medics discount code link as well. So don't forget to fill that out for a certificate, as well as discount codes for Teach Me Surgery and Pass the MRCS. Also be sure to complete the Google form, as I said, for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. Our next session will cover urology, but more looking at the presentation of urinary retention. That'll be tomorrow, Tuesday, 1st of April at 6:30 p.m. So we'd love for you to join us again. Make sure to follow us on our social media platforms, and the link for these are available in the chat. And you'll also be able to receive updates on the upcoming sessions via these platforms. We'll also be posting SBAs on our socials for additional practice, so keep an eye out for those. And don't forget to visit our website, where you'll find a resource bank with materials not just for this session, but for all other sessions in this teaching series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. To access them, simply create a free account on our learning portal. We hope you found today's session valuable and engaging. So thank you again for joining us, and we look forward to seeing you at our next session. Thank you very much, everyone.